Now, in order to compare these threads, I recommend that you go have a look at this video on the IMCAS Academy website if you're a subscriber to IMCAS Academy. This is a talk done by Dr. Pierre Nicolau, and he talked about the science behind different threads. And I'm going to take some of his material here. So he's talking about how different threads material tend to dissolve at different times. So for PDO, they tend to dissolve over about 6 months. For Aptos, which is PLA plus PCL, they dissolve over about 9 months. And for Silhouette Soft, PLA material generally dissolve over about 18 months. And also the types of collagen that these threads stimulate, that's important as well. So you've got actually 29 different types of collagen in the human skin, but only 2 types of collagen that's of interest to us. You've got your type 1 collagen, which are made of the thick fibers, and this is the type of collagen that we want for skin support. And in normal skin, the type 1 collagen is made of, that is 85 to 90% are made of the type 1 collagen. Whereas type 3 collagen is the building block for scar tissue, mainly. So these are made of much thinner fibers, and they don't last as long. They don't give you as much support, and they generally gets broken down over about 6 months. So if we were to compare different types of threads, which I think it's very theoretical, because it's really hard to compare these threads. But if we were to, based on some theory, you got Silhouette Soft, Aptos, and Mint. Silhouette Soft made of PLA. They have cones on the threads, and supposedly PLAs they dissolve over about 18 months. And they predominantly stimulate type 1 collagen, and the estimated clinical longevity, which is the cosmetic result, because the cosmetic result is also caused by the duration of the collagen as well. So if you stimulate more type 1 collagen, there's supposedly more longer cosmetic result. So theoretically, Silhouette Soft should give you about 18 to 24 months in cosmetic result duration, even though the threads would dissolve over about 18 months. Aptos, they are made of PCL plus PLA. They are barb threads. They stimulate mostly type 1 collagen, and they should last, their cosmetic results should last about 18 to 24 months. Mint, they are made of mainly PDO. Well, they are 100% PDO. So they're barb threads, and they dissolve usually over 6 months, and that's actually in their product disclosure. And histologically, they tend to stimulate mostly type 3 collagen. So the duration is usually about 12 months, and I've spoken to some Korean manufacturers. They actually mostly they're in the process of moving away from PDO and changing their material to more PCL type threads, and actually Ultra V's have got 2 different types of material for the same design. So Ultra V have a PDO version and also a PCL version as well. But the thing is, all these is I think it's very theoretical, because you can't. There are lots of other factors that, like I mentioned, it depends on the patient selection. So your patient's age, skin quality, the metabolism, and also the practitioners' techniques and skills. That's also important. So how long does a procedure last? I think it really does really vary, and this is purely a guide, and it's purely theoretical. This is an article that they did some serial biopsies on Silhouette Soft. So they found that even at 24 months, there was still some thread material left, and there's still some type 1 collagen left even at 2 years after the procedure. Now, that's based on, I think, 2 or 3 people that inserted the threads into the skin, and they did serial biopsies on. And they found that predominantly Silhouette Soft stimulated the type 1 collagen. Now, this is an article about PDO threads, and they did PDO threads on 160 patients, and they have found that there was very little result after 1 year. And these are done by a group of Italian plastic surgeons. So they didn't think there was any result beyond 1 year, which is consistent with the theoretical table that I talked about before. So the points to note here is that the lifting capacity will depend on the practitioner's technique, planning of the threads, the number of threads used, the patient's skin quality and lifestyle. The longevity of result will depend on the patient's age, skin quality, lifestyle, number of threads applied, and also the pricing of your threads will depend on the number of threads required, and also the patient's skin quality and degree of sagging. So the third P in the in achieving a successful thread lifting outcome is the practitioner. So how the practitioner manages the patient's expectations and the practitioner's skill and techniques will determine the outcome of the treatment. So to manage the patient's expectations, we don't want to overpromise. So I always explain that it's not going to give you a plastic surgery result. It's not a surgical facelift. So I'm very realistic about the longevity of the threads, and be realistic about the pricing. So if you think that the threads is not going to last very long, then maybe price it accordingly. There are also other treatments that may be required. These days I quite often add fillers or Botox or other laser treatments with the threads as well at different stages. So the practitioner's skills will depend on good knowledge of anatomy and applying the correct techniques. So the most important thing in thread lifting is to have a good understanding of anatomy and being able to insert the threads at the correct depth. So have a think again about the 5 layers of the face. If you place your finger on your cheekbone, you can feel the bone. So between the skin where your finger is and the bone is a very narrow distance. And within that very narrow distance, there are 5 layers. So to place the threads in that exact subcutaneous fat layer in layer 2, the practitioner must be very precise with the technique. If the threads are placed into the incorrect depth, too superficially into the skin, so what will happen is that you're going to cause the patient pain immediately. There's going to be skin tearing, skin dimpling, and nodules. And if the threads are placed too deep, hitting the muscle, then you're going to cause pain, bleeding, nerve damage, muscle damage, and a poor result because the muscles themselves are not very mobile. We want to lift the mobile structure, which is a superficial fat layer. I just want to highlight here most of the dangerous structures are below the muscle. So the arteries, the veins, and the nerves, and your threads should be above the muscle and away from the dangerous structures. So here's a case study of a combination treatment. This is a 76-year-old man with severe volume loss, advanced skin sagging, and heavy jowling. He's actually my father, and he asked me if I could make him look a bit younger with threads. I thought he was a bit too far gone for thread lift, so sorry, Dad. But and then it was his birthday coming up, and he was going overseas to visit some friends. So I thought, considering he's not expecting to look 25, I'd give it a go. So I injected some filler deep to volumize his deep fat. And so 1 ml of Vilance. Then I used 2 pairs of Silhouette Soft on each side. so 2 pairs, so 4. So, and 2 pairs of mint threads. This is 2 months after the treatment. And he's now about 7 months now down the track from the procedure. And the other day he went to the supermarket. You know, right now we have the coronavirus, that the elderly people get their priority shopping in the morning. He actually got asked for ID because they didn't think he was over 65. So, so the key message here is that you may need to combine other treatment options, and I sometimes even combine different types of threads. And these are some other results.
So Gordon,
yeah,
why do you combine the threads? What are the advantages of combining the different threads?
That's a really good question. So going back to my dad again, so I find that different threads may grab different ways. So you've got your silhouette soft out that are coned, that's got cones on them. I find that those cones seem to grab the fat better, whereas the barb threads seem to grab the skin better. That's just a theory, but I mean, I can't prove it, but I do find that different threads seem to grab the different layers slightly differently. So sometimes I will layer them differently. Now, the other reason for that is, Sean, is that, like I was saying before, the different threads have different duration. So I was concerned that if like what, in theory, like what they said, if PDO threads, like the mint threads alone, are going to last only 6 months, then by adding Silhouette Soft, I was hoping to add the duration as well. So I'm just taking those considerations into account. In fact, my dad was probably the first experiment where I added different threads to see if I get a good result. So, and it's worked. So
I think there's definitely a paper there for you, Gordon, to do a randomized controlled trial of using just one
absolutely
type of thread and combining.
So it's quite frequently now. So I mean, Silhouette Soft is generally my go-to threads because they seem to last longer, they grab better. But in some patients, I would add some of the PDO or some of the barb threads on top of the Silhouette, and in the same session, and crossing them sometimes to add a bit more grab. So they all work differently. Yeah, definitely. So these are some of the other results. So quite often I add fillers with threads. Sometimes I just do threads by themselves. So here's some learning resources if you're interested in doing any further training. So Cosmetic for Silhouette Soft, Mara Aesthetics for Aptos, and Mondio for the Mint. They all have very good trainers. I'm the trainer for Cosmetics. I find that the Silhouette Soft is probably the best threads to learn from, because I find that they're the easiest to learn from. As you're like to teach beginners. I mean, I've taught all these threads, but I find that for beginners, it's the best threads, best type of threads to get your layer right. For pot, I was interviewed by Inside Aesthetics. It's a cosmetic medicine podcast. They get downloaded about 30,000 times per month. So there's 2 episodes now. They've interviewed me on thread leaves. I also teach at this course with Matthew Stefanelli in Paris, and we're trying to organize a course in Melbourne when we're not in lockdown. So I also designed this thread leaf masterclass in Dubai, which I taught at in January, where I taught Silhouette Soft, the PDO, and Aptos all in one day, hands-on, and I taught that to a small group of doctors from around the world. And that was very well received, and that was So I've definitely found that with the students that they were able to get the Silhouette Soft as a much easier, quicker learning curve.
Now, Gordon, I've heard. I don't use threads. I'm very interested in learning.
Sure.
I've heard that after the procedure, there's a little bit of hand holding involved.
Yes, absolutely.
Client.
Yes, yeah. So
Can you
the other
speak
thing
about your experiences with that, and what are you hand holding for?
that's right. So I don't know about the other companies. So Cosmetic right now, they now have a 3-tier training program where once you've done your first initial level, then you have another level where the trainer will come to you, and then you once you've got some practice doing some basic stuff. So they have 3 levels of to advance you that way. But I think it does heavily depend on the trainer. I have to say, someone needs to explain to the trainee how to get to that second layer, that subcutaneous layer, because I feel that's really not well taught anywhere in the world, and I'm a little bit fortunate in that way that I was able to. So I've attended 10 of these anatomy dissection courses where we put fillers and threads into fresh cadavers. So pretty much every time I learn a procedure and I go to one of these courses, I will test my threads and product on the fresh cadaver and see where it's gone. And that's what also these courses are teaching these students as well. So I guess in a way I have a bit better feel for getting that right layer. And I do teach, I put a lot of emphasis on anatomy and how to get to that correct layer. And once you know how to get to that correct layer, it's the same for all types of threads. So I started learning from Silhouette Soft, but now I do Mint, Aptos. It's the same technique. It's the same understanding of anatomy. It's the same layer.
We should actually talk, because obviously from the emergency medicine perspective, we do a course 3 or 4 times in Melbourne where we get fresh frozen whole cadavers.
Yes, absolutely. I've been talking with the
afternoon.
Yeah, absolutely. I think we need to get, and this is what we've been trying to, we'll definitely talk about that, as well. Getting the fresh cadavers is really important.
Well, we just use the same cadavers because they're being used for another course, and that we don't really do. We do a burr hole in the head, but the face,
okay.
we don't touch the face at all. I reckon there's we should talk about this offline.
Absolutely. That's great. That sounds good. Okay, awesome. So there are many different types of non-surgical thread lifting on the market. We need to differentiate difference between non-lifting threads from the lifting threads with the aim to reposition the skin. The successful outcome of a thread lift will depend on the patient, the product, and the practitioner. In order to achieve a successful outcome in thread lifting, the practitioner must be able to manage the patient's expectations and have anatomy and use the correct techniques, which can only be achieved through ongoing training and practice. So that's the end of my presentation. So I'm gonna, any questions before we move on to the article?
I'd like to ask a question, Gordon, if that's all right.
Yeah, sure.
I think there's quite good research that shows that the primary thing that's happening with a face as we get older, loss of volume.
Absolutely.
So I see quite a lot of patients who come in requesting a thread lift.
Yes.
The vast majority of them, I look at them and I think, you don't need lifting, you need volume. And your father is a fairly classic example of that. I mean, that's a face that needs volume.
Yeah.
So one of the issues I have with thread lifts is one of the issues I have with thread lifts. But one of the main issues that I have with thread lifts is, for the cost of a thread lift, I can put quite a lot of volume in a person's face. And I feel that I can get a much more reliable effect for them
Yep.
and usually a much longer lasting effect for them, whether I'm using a collagen stimulant or a hyaluronic or a combination of that.
Yeah.
So what makes you decide to do a thread lift on someone rather than revolumizing them?
Okay, so these days I typically do both. If they're coming for like an aging type sagging scenario, because if you think you're absolutely on the right track, Chris. So if you think about it, the aging process starts with the volume loss on the bone resorption. So bone resorption and deflation of the deep fat. So if you think about that, so the volume loss happens first, and then all the superficial structures start to sag down. So the analogy that I give to my patients is like, imagine you've got a house and your foundation starts to collapse, then the house will then sag and collapse. So what you need to do is first build that foundation with the filler, the filler. I generally inject the filler deep onto the bone, which is in that on the periosteum, which you're actually on the periosteum, which means you're in the deep fat compartment. So once you volumize that, you're supporting the ligaments around the deep fat, and that's supporting the superficial structures. And then I will put the threads on top to lift. So my patients understand this analogy where I said you need the filler for foundation, and then you're going to need the threads to pull the house back up. So if you just put, and I know where you're coming from. If you just put the threads in without the support of the deep with filler, with the volumizing deep support, you're probably not going to get as a good result. Now, having said that, why do I use threads in that superficial fat compartment? Well, I think Mariana sent us a very good article through this afternoon. Now, that article, what that's saying is if you're putting filler, HA filler, in the superficial fat compartment, you're just making that compartment heavier. So I support the idea of putting filler deep to support the volume deep, and that's the foundation. And then the threads, as we talked about, it builds collagen over time. So I find that my threads, if I'm using Silhouette Soft Say, that's supposed to have collagen and lasting close to 2 years, then I find that lasting a lot longer than putting an HA filler in that superficial fat compartment. So I do both.
Okay.
Any other questions?
Yes. Can you hear me?
Yes.
Yeah. Hi. Quite a few friends of mine who are plastic surgeons, they are against the thread lift.
Yeah.
They say it creates a fibrosis, and then later on, when patients want to have a proper surgical lift, it's quite difficult for them. What do you think about it? Because sometimes my patients are quite marginal, like in between. I'm not sure, should I refer them?
Okay.
Or should I?
So the plastic surgeons who haven't actually done facelifts on people who's had thread lifts, they will say that to you. There's who's the guy? If you talk to Ian, Sean, what's the plastic surgeon's name? Ian
Carlisle.
Ian Carlisle.
Ian Carlisle.
Ian Carlisle. I spoke with Ian Carlisle. He says there's absolutely no problems, and he does.
Ian's using a lot of mid threads at the moment, is my understanding.
So he's a Ian Carlisle is a plastic surgeon, and if you ask him, he says there's absolutely no problems when he does a facelift on someone who's had thread lift. There's not too much fibrosis.
Right. All right. So it's more a competition for the patient.
Absolutely, because anyway. Ian tells me I don't do facelift. Ian does, and Ian tells me there's no problem.
I've heard the opposite of that, Gordon. I've heard from another plastic surgeon that it's difficult to to do a facelift after thread lifts. And this patient didn't actually reveal the fact that she had a had a thread lift to the surgeon before she had her facelift. So he didn't know that she had a thread lift. So he just found it hard, and then subsequently found out she had thread lift. But I guess I mean, that's the basis, half the basis of why thread lifts work and stay, because they create that fibrosis and scarring. So I imagine that's necessary. But, you know, I mean, facelifts can still be done afterwards. I don't think that's a problem. But
yeah, I remember, Gavin, some of these threads are permanent threads. So some of these patients had gold threads put in. That's 10 years ago. They're still in there. So when the plastic surgeons say, "Oh, it's really hard to dissect through," I don't know what threads we're talking about. So the threads that we've been talking about tonight are the dissolvable threads. So I presume they're all disappeared by the time. Yeah.
Well, I mean, my understanding of dissolvable threads is that they actually probably create more fibrosis and scarring than the permanent ones, like a dissolvable suture might do. Am I right in saying that? But
not according to Ian Carlisle.
Sorry?
Not according to Ian Carlisle.
Okay.
Could I just put my 2 bobs worth in here? Can you hear me, guys?
Hello. Hey, Tony.
Yeah. Hi. I've done facelifts, surgical facelifts on patients who I had previously done thread lifts on, and also on patients who've had thread lifts from other doctors. And in fact, I've also done facelifts on people who've had thread lifts that didn't disclose them to me, and I then found evidence of the threads.
Yep.
There was no problem, really. And in any of those situations, I always found it very easy to do the dissection. So I don't know where this plastic surgeon thing is coming from. They're probably just talking to each other, and I would say it's received wisdom. What does disturb me, though, is that I haven't found very much fibrosis around the threads that I have located during surgical facelifts. So that is a bit of a concern, I guess.
Yeah.
Actually, the whole idea of thread lift was implemented by plastic surgeon Marlene Sulmanidze, who was enhancing his facelifts by threads. And then Aptus was born pretty much by the family of plastic surgeon, and most of the trainers for Aptus, at least in Europe, are actually plastic surgeons. And what they say when this question was asked, when I was in Aptus training, they said, look, very, very old-fashioned technique of facelift actually might be a little bit more difficult. But we would be really surprised if some plastic surgeons still do this very old-fashioned technique, because most of us are more up-to-date and we actually learn much more modern techniques, and that's why for us it's not a problem. And regarding, Tony, your question about your statement about fibrosis, in IMCAS this year, it was interesting research from dermatologist, I think from Ukraine. He actually himself put these threads into mice, and then I think 6 months or 2 months later, he actually dissected, and he found that it's a very minimum collagen stimulation. So, and he found that the cocked ones actually have more collagen stimulation, but the the mono threads, they have barely any.
That's right. The mono ones are mainly made of PDO. And they stimulate mostly type 3 collagen.
Ron Farner here, Gordon. Can you hear me?
Yeah, hi, Ron.
How are you? Gordon, you were outlining, for instance, with silhouette that you were theoretically expecting about a 18-month result.
Yes. Theoretically, I'm expecting a 2-year result.
Yeah, is that in clinical practice? Is that the case? Do you promise a couple of years?
Do I promise my patients that?
Or do you indicate to them they'll get about 2 years result?
What I say to my patients is, from my experience, patients' photos still look good after 2 years.
So the other issue, if I can ask a question, that the other issue I have with thread lifts, not to beat about the bush, I've done thread lifts on and off for like 20 years. When I was using permanent threads in the past, I got some really good results with them. I've treated a lot of patients, well, I've treated a few patients with silhouette. I've done it with 2 or 3 different trainers, including a plastic surgeon. I've seen patients who've had silhouette threads done with several other doctors. I'm really yet to see a single patient who's really satisfied or where the treatment has met their expectations. And I'm talking about being very, very careful with patient selection and being very, very careful with placement. I just, in my hands, I can't get a long-lasting result. They look great for a while, but it's a short while. And my experience has been, for $2,500 or whatever you're going to charge for a thread lift, if I put $2,500 worth of fillers in a patient's face, I'm pretty certain they're going to be happy, and I'm pretty certain it's going to last, 1 to 2 years, even longer sometimes. I just can't get that from a thread lift. So I don't know if that's my technique, but as I say, I've done it with 2 or 3 different trainers, and I think my technique's pretty good. I just can't get a result that's going to really last for people. I've given up on temporary threads at the moment.
So it could be so that the techniques and practice about threads have evolved over the years. So what I was doing about 3 years ago, what I was taught probably 3-4 years ago, what I do today is almost completely different. So in terms of the types of threads we use, the placement, the techniques, the pattern of threads, the number of threads, that's changed a lot over the years. I know where you're coming from, Chris. I would probably say maybe 4 years ago, I would say, like, okay, I'll give you an example. 4 years ago, I was told to only do 2 threads of silhouette on each side. Sometimes we would do like a U pattern or do a V pattern. These days, I would do 4 on each side. That's considered pretty standard. I would do 4 silhouette plus deep support volume with filler, and sometimes I will add other threads. So, and I have to say, I don't know, like I've seen some trainers teach threads. I mean, I know a lot of people, they say they're experienced or plastic surgeons. I've taught plastic surgeons threads, and plastic surgeons don't get this. They're good at cutting, they're good at stitching, they're really good at doing microsurgery, reconstruction. This is a different skill to plastic surgeons. I find that it's really important to get to that correct layer. And if you're not in that correct layer, in the past, I've been wrong too. Maybe 4 or 5 years ago, I was going too deep and I was not catching the right layer. There was not much lifting. I wasn't using enough threads. So all that. These days, I wouldn't charge $2,500. I charge close to $4,000 for every threadly procedure, because I'm putting that many threads in plus filler. And the patients are happy. They're much happier paying a bit more for more threads and the filler support, and they're getting much better result. So I'd rather not charge less and get no result. I'd rather use more material and get result.
Yeah, correct me if I'm wrong, but there are certain areas on the face when it's better to use threads than filler. For example, when patients have jowls, you can't continue pumping them up, right? So threads would be a great thing to use here, let's say combined with HIFU, Ulthera, and fillers as well. So it's a good option to have.
Yeah, so I just want to go back to this, I was talking about the aging process. So for the jowls, if you have a look at this sector 2 here, that's the part that sags. That's the part of the superficial fat that sags. So this orange section has the thickest layer of the superficial fat, and that's the most mobile part, and that's the part we want to lift. Now, the jowls, the nasolabial fold, and marionette folds, these are, if you have a look at this, there's a transition of fat from the orange colored fat here to the more white colored fat here around the mouth. So around the mouth, you've got more fibrous fat. It's known as type 2 fat, also known as white fat. It's the white fibrous fat. So there's a transition of fat thickness from here to here. So these folds occur at this, what we call anatomically known as transition zones, where the fat changes. So these are actually not, at a superficial level, these are not zones of volume loss. These are zones of transition where there's a volume, these are zones of sagging. So I find that I would volumize deep, and I would reposition these areas with the threads in the superficial fat layer. And in that you're actually treating the cause of the problem, because the problem here is not volume loss.
Exactly, that's why I said it, because you can compensate with fillers, let's say, for the same amount of money. You can use, I don't know how much, 10, 12 syringes, but eventually everything will drop again. When threads, it's a good option.
So the problem, if you probably see some people, if you put too much filler in the nasolabial folds and the marionette folds, when they smile, they have this very weird look. They look very overfilled. That's because we're not treating, if you put too much filler there to mask those transition zones, you are just overfilling an area that's not an area of volume loss. That's an area of sagging and transition.
No, I do agree. That's why I was trying to comment on the previous comments.
Yeah, so that's why I think there is a place for threads in that superficial fat layer. Yeah, I mean, I think filler definitely has their place in terms of the deep structures. I think let's move on to the article that we're going to talk about on threads. So Larissa has put in one of the articles that's got thread lifting on it. So that's the article with the PDO. Let me just get to that. So if you can just pull up that article with the Korean, this one here. So it's by Kang. And so this one, I'm not sure if you read it. So I find this article quite interesting. I didn't think it was very useful, but it was interesting. Well, what they've done is it's an article. Basically, what they did is they got these thick PDO threads, and they are the lifting PDO threads, not just the floating ones, not the big thick lifting PDO threads, and they cut them in half, and then they folded them, and then they inserted subcutaneously. So what they've done here is so like they put them into little cannulas, they folded them and they put in little cannulas, and then they put them in these wrinkles, these static wrinkles on the forehead and in the frown line. So use them as fillers. So basically they took these lifting PDO threads, but used them as for a non-lifting purpose, for filling. So I thought that was quite interesting. Because they are actually now these articles written in 2018. These days, Aptos actually have threads designed for that purpose. They have tiny little threads that are sort of twisted around, and then they will expand in the tissue. So there's spiral double-stranded thread that will expand inside subcutaneously to fill these lines. So this article they had 33 Korean patients, and overall they found the results to be quite satisfying. But this is at 2 months follow-up with PDO threads. So I don't know. Firstly, we don't know about the duration. And then they talked about, it is a little bit unclear where the entry point was for these threads. So according to this, they said it's about 1 centimeter away from the wrinkle, and they will just slide it in with these cannulas with the threads, and then they will sort of fill them using this kind of V-shaped pattern. And then the threads will then stimulate collagen and then fill these wrinkles. Now, of the 33 patients, they had, looks like to me, they had anyone from 37 to 59. So I don't know. I mean, I don't know how, that's a big age range of the 33 patients. Now, the other thing was I read here that they had, of the 33 patients, there were 3 patients that had complications, which is a pretty high complication rate. I found that's almost 10%. That's like I have to say I've out of the a few 400-500 cases I've done, I don't think I've had any sort of these kind of complications they're talking about in terms of threads hanging out or skin necrosis. I mean, anyway, they took the threads out, but this tells me that whoever was doing the threads, he didn't get his depth right. He had the wrong depth. So he didn't have. I think maybe he didn't have the right technique. Having said that result is quite impressive there, and. But anyway, that's my take on this article. But I thought that the idea itself was quite interesting, using these threads as a filler. So I don't know, what do you guys think?
When I was in Korea last year, I actually had a training in South Korea in Seoul for thread lift. And what they do, my understanding routinely, when they insert the classic thread lift into mid-face for this kind of like tissue repositioning, you have a little bit of thread lift left. It's maybe 4 centimeters or 5 centimeters. And PDO is quite expensive material. And instead of just throw this away, what they do, pretty much what is written in this article, they just fold it in half, reinsert into a cannula, and then reinsert it in the areas where they have the deepest and the most challenging wrinkles. They pretty much ask you, and I agree with this article, it's most of the people show here or here, and then they just reinsert while it's like take them 2 minutes additionally. And it's like routinely for them. For certain patients, they do so much lock when it's like a lot of the threads left, like half of it's left, and they just reinsert again, like enhance near the ear or wherever patient need. But if it's a little bit left and you don't want to throw it away, that was pretty much technique which I found quite interesting, what they do in Seoul last year.
Yeah, I mean, like, as you know, Aptos have created these threads for this kind of purpose. Like that's the nanovitis. Some of the Aptos threads have already they're designed for wrinkle filling. I just find it interesting where they use one of these threads that they normally use to lift, to reposition the skin. They cut them and then they use them as the filling type function. Okay.
I think there are better options to deal with those wrinkles than using threads, and I think that complication rate's too high. If you had that complication rate with Botox or botulinum toxin, you'd be in trouble.
Yeah, exactly.
I think it's a substandard treatment for.
I think the techniques that's pretty bad. But I haven't had with threads. I found threads to be very, very safe. I don't think I've never had one case of infection or necrosis. They may get some dimpling in some patients, but that always resolves over 2-3 weeks. But if you place them in the right layer, in the correct layer, in the subcutaneous fat layer, that shouldn't happen. So yeah,
I definitely agree with that, Gordon. And you're a very skilled operator, but there are a lot of cack-handed fools out there with a number of syringes in their hand and a number of devices in their hand too that aren't going to have the success that you have. So we have to translate these treatments to your general cosmetic physician who isn't as skilled as you with threads. So I think it's a dangerous position.
Yeah, that's right. That's right. So
unless you're very skilled, and they didn't actually say that in the paper.
That's right. So I think it's the same with fillers as well. I mean we've got good injectors and bad injectors. Same with threads. So it's the same with any tool. All right, I guess that's me. I think, is there any other presenters? Larissa, someone else presenting?
Yeah, we have someone else. Thank you very much, Gordon. It was actually quite interesting. I found it amazing amount of knowledge. I'm sure everyone else the same.
Now, I'm going to, how do I switch this back to you now? Hang
on. Yeah, that's interesting moment. So we have 3 presenters.
You're hosting now, Larissa. So I'm going to stop share my screen and then see someone else can share their screen now.
Okay, we now can see each other. That's great. So we have, it's pretty much like informal journal club. So whatever people feel like they can go. So we have Rachel, who will talk about acne treatment today. And we have Dr. Gavin, who will talk about, I don't remember, Gavin, what you're talking about.
You got to unmute, Gavin. Unmute your computer.
Yeah, guys, you can unmute yourself as well.
No core needles versus blunt cannula subcision. That's what I'm talking about for acne scarring.
Okay. So, Gavin, maybe we can start with you. So, do you know how to share your screen?
Yeah, so this is quite a straightforward article. I won't share my screen. It's
I will share mine.
But basically, it was done in Tehran. This study where they had 34 split faces, and they did a split study of one side was blunt cannula subcision for acne scarring. The other side was using a no-core needle for subcision of acne scarring. And I mean, I think most of you probably be familiar with the difference. Blunt cannula, you guys, I'm sure you know what a blunt cannula is, which we use for fillers. No-core needle is like a needle, which it looks like a little spade or almost like a slight. It's got like a scalpel edge to it, and it's triangular at the top, and you can use it to to cut as well a bit. So it's got a cutting edge. It's obviously a lot more aggressive than a blunt cannula when it comes to this treatment, and they wanted to compare, which was better, and they can also compare the side effects in this study. So they did 34 split faces, and they reviewed people at 1 week, 1 month, and 3 months. It was a single procedure only, and they said they were doing rolling acne scars only. So there's no really mention of the technique they used, other than the fact that it was either a blunt cannula or a no-core needle, and there was no mention of the size, which is interesting, of the cannula or the no-core needle. So was it a 25 gauge blunt cannula, or was it a 18 gauge blunt cannula? They didn't say. So the technique was that they did one side of each, and then they were assessed by both the patient and 2 physicians. Doesn't say whether it was the physician performing the treatment or not. It actually was no mention of who performed the procedure. It was really interesting because they said that they did the subcision and then they used the suture material. They used sutures to suture it back up. I don't know what they were doing, but I've never used the suture material with subcision before. I usually just enter through a needle hole. Never had to make a cut. Look, the photos that they showed before and after were a little bit dubious. There was only 1 week post procedure, so there's going to be still a lot of swelling there. And in figure 4, which is on the next page, they've got some boxcar scars there, not rolling scars. So I don't know whether they properly excluded the types of scars that they said they would. So basically, they found the overall results was that they found that pretty much both physicians and the patient rated blunt cannula dissection or blunt cannula subcision better than the no core needle. So ironically, the less aggressive method, the blunt cannula subcision, outdid the no core needle subcision, which is probably what is somewhat counterintuitive. But one of the main things they found was there was seriously less side effects with the blunt cannula, so less bruising, less nodules, less downtime. I certainly found that in my own experience as well with blunt cannula dissection, subcision. I get a lot less downtime than if I was to use a no core needle. Using no core needles to do subcision is really traumatic for the patient, and you pretty much invariably get a massive bruise on every one you do. So you have to make the excuse to say that bruising is a collagen stimulator, and that's going to help you. But I've basically had I've had similar findings myself. I don't use no core needles anymore for subcision of acne scars, and this study sort of reinforced that fact for me. So the other thing is I didn't mention earlier that I guess the technique I use with a no core needle is I go in and I sort of try and do this sweep underneath the scar. So I try to sort of almost cut the adhesions of the scar to release it. But with the cannula, generally I'm just sort of going straight in and out and doing some fanning sort of methods in different directions rather than doing sweeping with a cannula, because there's no cutting edge with a cannula. So the no core needle, you can sort of do a windscreen wiper method, movement and get that cutting happening. So this study sort of concluded with a lot of other options for acne scarring. They went through some general information about other methods that could be used. But there was no real mention of the combination of filler and subcision together, which I think is a really powerful combination when treating acne scarring. I don't. Do many of you guys use filler and subcision out there? Anyone?
I certainly use a lot, and I think I know what they mean by suture. Because in some countries, and I think it was somewhere in the Middle East, they just have to practice very budget-driven medicine. And instead of expensive filler, they just used like a Vicryl or other absorbable sutures as a kind of collagen stimulator mesh under this subcision area.
Right.
A couple of times.
It was very hard to understand the article. They just said suture and didn't say. I've never heard of that being done before, but that would be good, actually, interesting.
I'm currently practicing in the Middle East, so I know this technique beforehand. So, and it's very, very common. For example, I had my rotation in an army hospital where lots of low-income people coming, and yes, they actually cutting and suturing the scars. It's horrible. It looks horrible, really, but it works 50% ish.
Yeah. So I mean, what do you guys use out there for rolling acne scars? Does anyone have an opinion on what's the sort of the most effective or the best treatment for rolling acne scars?
Blunt cannula 22 combined with fillers is good.
Yeah.
It's a combination of a number of different modalities. You want to hit that scar from as many different angles as you can get. So subcision, filler, radiofrequency, skin needling, whatever you can do to distribute.
Yeah, definitely. I think I agree, Sean. That's definitely multiple
Fraxel,
modalities is the best.
Yeah,
depends on the budget.
Just interesting with this study that they didn't really, the randomization was a bit crazy. They're small numbers, so 34 patients, of which 73 were female. So is there a female bias? They didn't even look at that because they didn't have an even split between male and female candidates.
Have you been to Iran?
I've never been to Iran, but if you're going to put a paper in the Journal of Cosmetic Dermatology, this is going to get ripped apart by anyone that sees that. That's not a completely randomized trial.
But it's very common to Middle East, unfortunately. Every paper published here, mostly male participants. So that's an issue we're having here. I'm in the middle of research right now, and I can't get enough female participants, really. It's a big deal here.
All right.
Yeah.
I see they've referenced both of Greg's papers, and that's it's quite extensive. We've read both of those papers, 8 and 9 on the references. I mean, those are both excellent papers, and we'll talk about a number of different modalities to treat post-acne scarring.
What I found interesting, though, that I almost never do subcision without preparation first. Quite commonly, people who come for subcision, they already have, they still have acne, and I would not feel comfortable to do any procedure while they are having active infection. Also, I found when you prepare it healing better, it's better results. So I usually have a look at them and very commonly give them vitamin A, tretinoin, retin-A, something like that. If it's Fitzpatrick 3 or more, I can give them hydroquinone for 1 month or so. And then when they come, I feel more comfortable to do subcision. And another one is a follow-up, because I found, as you correctly said, it's combination which works the most. Just subcision itself is not enough.
Gavin, I've got a slightly off-topic question for you.
Go ahead.
So with the no-core needle, have you ever tried to use that to subsize the nasolabial fold? Because we have a doctor at our clinic. You probably know Simon Rosenbaum. He subsizes the nasolabial fold with the no-core needle, and then he puts threads in to lift it, and he gets great results.
Does he get much bleeding from the facial artery?
He's very inventive. He's got a lot of good ideas. I have never tried that before, no. But I'm not sure what the basis of that is. Is there some tethering of the nasolabial fold there that needs to be released? I'm not sure, but I can't say I've ever tried that. I've only done subcision for scarring, pretty much.
One of the problems I ran into when I was subcising scars, when you don't get that patient back in the next few days and treat the bruise that you're inevitably going to cause with that no-core needle, is I've had staining. And these bruises have lasted for a long while. You can't hit them with a laser after they've sort of deposited all that hemosiderin in the tissue, and they can last for a while. So
you've got an XLV though, don't you, Sean? You can zap it with.
I do, but these guys didn't come in within a week for the XLV. They came in like 2 or 3 weeks later with this staining on their face, going, "Oh, I bruised, but it cleared up, but we've still got this staining." And I'm like, "Oh shit!"
You can use a Q-switch NdAg or a Pico.
I don't have one of those.
You got one?
I'll send them to you, buddy.
All right. Well, I'll send you something else in return.
Could I just give my own opinion about what the nasolabial fold actually is? It's not a ligament. It's not a kind of a line that attaches one structure to another. It is a boundary point between skin on the upper lip that is very, very tightly tethered down to the underlying orbicularis oris, and the skin of the malar area of the cheek that is not tightly bound down. it's not a ligament itself, it's just a boundary zone. How can you subsize a boundary zone? That doesn't make any sense to me. What are you doing? Are you tearing the skin off the orbicularis oris somehow? I mean, yeah, probably. What's that going to do? You know, this whole idea of subsizing the nasolabial fold to me seems bogus. I think if you want to reduce the depth of the nasolabial fold and you know, reduce its visual appearance, you need to lift those soft tissues of the cheek that are superolateral to it. There's no other way, I think, that would work.
Yeah, I agree.
Does anyone who does fillers of the nasolabial fold and marionette folds? You guys, anyone think that helps much, or
okay? I still do. I
actually do.
Sometimes I still do a little bit after thread lifts because once I reposition that fat pad, in some cases, some patients still has that superficial residual crease. Then you know the threads is not going to get rid of that. So I still do a bit of filler there sometimes, but I don't overfill those areas.
I can actually show you what I do. I open my website. It's actually subcision of the nasolabial folds. I've been trained for this technique like 100 years ago, back when I was in my dermatology training in Russia. And it's extremely old-fashioned technique, and it's not needle, as correctly was mentioned. It's too many arteries and other structures. It's actually blunt cannula, and you're not completely actually taking, like, separating everything. You're just making this this line less firm, and you pretty much blend it a few times, and then you have a filler or fat or whatever you want. But I personally, for these patients, I used a bit of filler. It's not a first line technique because it's a massive amount of bruise. It's very it's at least 2 weeks they will be actually healing. So I would actually say this is like a last resort when I already utilized other modalities. But this is what I've done with the blend cannula, and it's pretty safe. It was also research done in cadaver, and they had a look what exactly they're actually doing with this blend cannula. Sorry, my internet is very slow, but I have the somewhere I have the photo. Yes, here is a photograph. So it's actually a lot of fibrosis, and they show that's actually what we are trying to do. We're just trying to soften up the fibrosis and make the blend kind of not as harsh. And that's why, like, it looked nice, but I would not say it lasts long. I would not say it's very much worth it. You definitely don't want it as a first line of treatment for sure. It's quite painful as well. So, okay. Any other questions to Gavin about the separation? All good? All right. So we probably can move to Rachel.
Sorry, while you're doing that, can I just quickly add a point here about bruising from that Norco needle? Generally speaking, like I was saying about that subcutaneous plane, if you're in that layer 2, you're above the muscle, you're above the SMAS. All your arteries, like someone mentioned a facial artery there. You shouldn't hit it if you're in that subcutaneous layer. So I quite often do subcision with an 18 gauge needle, and I don't cause much bruising because I'm very, very superficial, and generally I don't hit the blood vessels if I'm above that muscle layer. So because your major vessels are below the muscle. So when I do thread lift, there's very minimal bruising because I don't hit that. Because I don't get below the muscle.
What text? a text from Kelly, I think it is.
I have an idea. Would you like to have a luncheon party on the weekend? We can put our own separate tables and our own front verges and have a chat and a wine.
Is that Kelly?
Who's that? Susan?
I don't think so. It was for us. All right, maybe we can move to Rachel, if you would like.
Okay, can you hear me?
Yep.
Okay, can somebody put up the article?
Yep. Give me one sec.
Thank you.
Here we go. Can everyone see it okay? Yes. That's good.
Now, this was a cute little article. It was a proof of concept study on a new formulation of 5-ALA in a thermosetting gel, rather than the typical 20% ALA that was used for photodynamic therapy of for acne. And the aim was to assess the efficacy and tolerability of the treatment using red light rather than blue light, because the red light gave better penetration, even though it wasn't the strongest of the activators of the protoporphyrin, whatever it is, and for treatment of the mild to moderate acne. It was only a small study with 35 subjects, but they seemed to be, again, 13 men, 22 women with mild to moderate acne. And it involved, sorry, I shouldn't be reading it on the screen because it's moving.
Oh, sorry.
Oh, that's okay. I've got my printed one in front of me. Okay, so the primary outcome was to look at the evolution of the global acne grade system at baseline. They did an average of about 3 treatments using the 630 nanometer red light, 15-minute PDT sessions every 2 weeks for a maximum of 3 treatments. And to assess the, again, skin tolerability, there was a score of 1 to 3, 1 being severe, sorry, 1 being no, sorry, 0, no discomfort, 3, severe discomfort. And the results showed very clearly that there was a very significant, like 70% reduction in the GAG score at the 6-month post after the last session, which was actually a pretty good result. If there was no other treatment for the acne at the time, so they just had the three treatments 2 weeks apart, 15 minutes of illumination after 120-minute incubation, and generally minimal discomfort and side effects, and quite a good resolution of the acne 6 months down the track, which was quite impressive, I thought. I'm not sure what else to add to that. Obviously, further studies, they recommend further studies to analyse it more, but it seems to have proven its point, or made its point. It's an Italian study done in 2018, I think.
Is anyone actually using this PDT at work, at their practice?
It's not in my area of expertise.
So I believe majority insurance, they actually cover it for non-procedural GP, so it's quite quite safe.
And given the good tolerance of it, I mean, using a 5-ALA rather than, I don't know this product. Is it one that's even available here?
It doesn't really matter.
You can get it compounded.
Oh, okay. Using 5% rather than 20, and if you can use low dose treatment and get a good response with minimal downtime, then that would be a great therapy for moderate to severe or moderate acne, mild to moderate acne. From my point of view. Comments?
I've never done photodynamic therapy with 5% ALA, but I remember probably over 10 years ago now, I did one young man with 20%, and he had such bad downtime, and I think we did it about 4 times on him. He would have had like 1 to 2 weeks of downtime, almost like laser resurfacing type of downtime. But the interesting thing was, I mean, this guy was a Roaccutane candidate, but he didn't want to be on Roaccutane. So he had terrible acne with scarring. And it worked. I mean, the guy actually, I bumped into him at several months ago at a shopping centre at Doncaster Shopping Town. He stopped me and he said, "Hey, I remember. Do you remember me? My name's so and so. You treated me over 10 years ago, and now my acne's gone. Thank you so much. That was the best thing ever." So that was one of my few patients that I did. It was quite funny to actually see him about 10 years later with his acne all gone. So, but I haven't had experience with the 5% one, but it is a treatment which works. You can afford the downtime and all that stuff.
Well, this one says there were no major side effects reported except for a bit of itching and burning and a bit of discomfort, a bit of pain during and after.
That's amazing. That's
yeah.
great.
Sounds good.
The dose is 4 times less than given used, so it's probably...
Yeah. No, it's got a lot going for it, and if you can get that duration of response, hopefully further studies will be undertaken.
Well, it's not a new modality. We used in medicine for quite a while, and as Gavin said, we can actually see pretty much compound anything we want. If you clinically believe it will be good for patients, pretty much anything we can order.
I don't quite understand what a thermosetting gel is.
That was my question.
It obviously didn't require occlusion. There was no requirement for occlusion, so it would be cosmetically acceptable, even though during their 2 hours of incubation or 120 minutes of incubation, they had to remain in obviously no light, so they didn't activate it. But it would still be fairly cosmetically acceptable.
That's right.
Results are good.
Does anyone have something to add to this article? Oh. All right. Would you like to move on?
Yep.
Thank you, Rachel. It was interesting.
About my first journal club.
Thermosetting gels are the ones that are liquid on application and they become solid with warmth. So like a mask, you paint it on and it stays where you've put it.
So it doesn't drip.
Yeah, when it's the skin temperature, it becomes like a mask.
Excellent.
Good.
That makes sense.
Yeah. So one more option for us for acne to think about and consider when we have some patients. And the last for tonight, guys, if you still not fall asleep completely, it will be me. So that's for dark circles. And I found it quite tricky area, dark circles, because it's a central part of the face. And people who see each other usually in onesie, they come to you quite commonly and ask, what can I do here? And I don't know about your practice, but I have quite a few. And this is quite interesting study about periorbital hyperpigmentation. They specifically excluded anyone who has vascular or age-related bone deficiency, or really any other reason. So it was particularly overpigmentation of this area, which they wanted to compare. Carboxytherapy versus chemical peel and versus mesotherapy. And I found all these kind of options are quite interesting, but the most fascinating study of this particular research I actually tell you at the end, because I was finding this research very fascinating. I'll tell you then. So they had 45 females. All of them had pretty much the same problem. And the type of carboxytherapy and they used is a classic. It's actually exactly like a protocol. It's once a week for 5 weeks. So where is that, they say? So, and the theory behind that transcutaneous carboxytherapy actually create new vessels, increase growth factors, supplies oxygen, nutrients, and that's why the body is supposed to heal itself. The second was very commonly used is chemical peel. I believe in Australia it's registered as a TB skin. They have like a pencil which is quite easy to really apply even for like beauticians really, and it has TCA 3.75% and lactic acid 15%, and it was the same. It was once a week for 5 weeks. Again, create controlled damage and regenerate, and that's why they have better quality of skin. And the third is a mesotherapy with a highly concentrated vitamin C. Again, 5 weeks, once a week, exactly the same for each modality. And the conclusion which they get, that all 3 modalities are effective in reduction, and they all improved and high patient satisfaction with a good safety. However, this is what fascinating part. You know, like through our medical career, we have a lot of drug reps and all this research who are flashed in front of our face, look, conclusion, it's all the same. And that's what actually I learned. Never trust conclusion. Go and look yourself and make your own judgment. And I can show you now what actually figures showed, because this is really, really cool. So that's pretty much description of how to use technique, which I also like, because when you want to do something, you have to see exactly how it's done in research. So in case of application, something you can actually see what technique was researched. But come back to numbers. This is how they've done the therapy. It's pretty much around the area with where are results. Here results, that's my favorite part. Okay, so improvement. No, it's not here. Sorry, guys, I'm not very well prepared, but give me 1 second. Yes, so group A, carboxy, group B, peel, and group C is vitamin C, yes. So excellent results in patient. Carboxy, 13%. My clinical judgment tell me that if almost 87% of my patients are not happy with what I've done, I wouldn't do this procedure, I'm sorry, but it's not high enough. If only 13% believe it's excellent improvement, then group B with a peel, it's only 26% actually said it's excellent. And with vitamin C, they actually said it's 40%. 40% say the results was excellent. So you can't really say it's equal when in group A it says 13%, in group C it says 40%. It's not quite equal to me personally. This is overall improvement assessed by, they use like a scale by assessors and physicians. And patient satisfaction is pretty much similar to what doctors saw. So it was 0 patient satisfaction with excellent in carboxytherapy. Again, as a doctor, we just like want to do a good job. So patients trust us, like what you believe is a good option. It was 6.7% satisfaction in the peel, and it was 33% with vitamin C. So, but if you look together with moderately satisfied and excellent, so altogether, on carboxytherapy, it's around 26% altogether who were more or less satisfied. 52% in pill, and around 60% of vitamin C people were satisfied. So for me, it's actually quite clear that vitamin C, assessed by both patients and assessors, were significantly better from my point of view. However, there is a catch when it comes to side effects of the therapy. None of the carboxytherapy people had to stop. Group B also, they were all tolerable. A little bit of very mild burning sensation, but otherwise they were fine. But group C, 2 patients could not tolerate at all. They actually had to discount them because of the pain. If you ever injected vitamin C, I think you know what I'm talking about. It's probably out of everything I injected in my whole life, this is the most painful injection. And I'm really impressed with these soldiers whom they get, that most of them actually tolerated this. It's only 2 people. Because in my practice, when I can see some very dark, like actual pigmentation, not darkness from vascular, from being thin skin or tear trough, whatever, actual pigmentation, actually brown pigmentation, vitamin C actually works. And that's probably the best what I've seen so far working. If it's injected, it actually works straight away, quite quickly. But unfortunately, you have to really be careful with consent of the patient. You can say, look, it will burn like really, really bad. Are you sure you want it? It's an acid injected in your eye. So are you really sure? If she's really motivated, if she really wants to say, and this is your regular patient, you know she's usually good with pain, I would say, yes, I do this. And it actually works. I can't even compare this to the pill. It actually works better. But yeah, it is very, very painful. So the results which they show here, well, I'm not really satisfied with this quality of the pictures, because when you assess in a scale lightness, it should be exactly the same light, but you can see by the rest of the skin, it's actually quite different. So I'm not convinced how accurate is this as reflection of actual results. Whom they excluded from the research, it was actually quite important, because I completely agree with that. These are types of patients I would never use vitamin C or pills. Where is that? So it's basically type exclusion. I don't remember now where it was. So, but I remember in my brain anyway. So it was pretty much vascular. Vascular is, I completely agree. It's not for vitamin C, it's not for pill. It's, you have to go with the reason why it's happening. And quite commonly, we have some actually systemic problems, such as anemia. I found a lot of my patients who have iron deficiency, they have these dark circles, and liver problems also associated, sinus congestion, no matter what is the underlying cause, infection or trauma or allergy, but they quite commonly have dark circles as well. And if they have underlying cause, whatever treatment you do, they will never be happy, because it will come back very quickly, and the money spent will be for them like seems like a waste. Here it is. So they also were doing a liver function full blood count in their and they yeah, here we go. So pregnancy, systemic disease cause like Addison disease. I think in general people with autoimmune disorders, they are not great candidates for any injectables really. They can give you so unpredictable things. Then periorbital eczema. For eczema, I really like actually in my practice the skin booster, just the pure hyaluronic acid, 18 milligrams per meal, no matter which brand you like. It's give them such a great hydration, and it has anti-inflammatory effect. Of course, if you combine with home therapy as well. And also they exclude someone who had laser treatment within 12 months, which is fair enough because laser treatment is a quite great treatment itself. So there is no point, I believe, in treating on top of this. And dark circle from vascular and teardrop, excluded by stretch test. So, which is fair enough. It's a different modality. You really have to use filler for these people. And the conclusion, as we discussed, it was fascinating that despite such a great, like, actual great numbers change, they had this this interesting conclusion. They all look the same. So that was the most funny part. So for me, this article is interesting also as a scientific interest, because as a doctors, we should be quite critical on what study was flashed in front of our face, and actually read and see, especially in cosmetic medicine, I found that we don't have a lot of very good actually evidence-based studies. A lot of them have conflict of interest, or you can see very weird design, they're open label, no conflict of interest disclosed, like all these kind of basic things. And as a doctors, we should be really careful, because if something goes wrong, we have to make sure we have a good basement to defend why we change our clinical practice, because we learn from research and we actually up to date with the knowledge, and we think critically and act in the best interest of our patients always. So yeah, this is my article, which I found, as you can see, very exciting. So if anyone would like to discuss this, how they treat the under eye area, it's probably time to do so.
Which percentage of vitamin C they used?
That's a great question, because they give quite interesting, it was quite big dose, which I personally never use in my practice. Let me find it. It was in description somewhere. So here we go. They used 10 mils injected intradermally, both into lower lips, 5 mils each eye. There is no percentage. It's actually a good question. First of all, 10 mils, I think it's massive amount to inject into eye. Like, I inject usually insulin needles, and it's like straight away so much swelling for the injection that you can't just inject like a lot, even if you really want. That's a good question. Which do you use? I usually use 20%.
Yeah, 20, 15. Depends on the brand. But 10 ml, they basically soaked the tissue and washed everything off.
Yeah, this sounds like they had some kind of soldiers who were tolerating like everything. I cannot imagine my patients. When they look at this big syringe into their eye, they'll probably jump and run away straight away.
Wow.
Yes. Fascinating, guys.
So, Laura, how long after the course of treatment would the results last?
I don't think so. They had a long term. I think they've done 2 months.
But from your own experience, what you do with the vitamin C, how long does it last?
It really depends, because you have to be really careful with patient expectations always. It's better to under-promise and over-deliver than the other way around. And I found that most of them are actually genetic. Like ethnics, or just some like in South Europe, Asians. Like if you ask your dad or your mom have the same, they usually say yes. And as soon as you tell to them, look, it's genetic, it's your genes, it will keep coming back. We're here just to maintain. If you'll behave yourself and you will have a good lifestyle, that will last longer. But even if you do the best in the world, because it's your genes, it will keep coming back. We will just maintain your beauty, really. From experience, it's approximately from 2 months to 6 months, but I never inject every week, like they suggested, because my patients are princesses. They don't want to come back.
Okay. I'm just thinking for the amount of pain that they're going to go through with their vitamin C injection, would they be repeating it that often anyway? Yeah.
In my practice, around 1 out of 10 patients whom I injected vitamin C on the eyes, 3 will never do this again. Pain. But 7 come back.
Yeah. Okay.
It's like girls can do for beauty a lot of things, and
yes. No pain, no gain.
they're quite motivated, I found.
Larissa, how many treatments would you do? I mean, this is 5 treatments a week apart. That's wicked.
Yeah, it's crazy.
How many would you have to do to just maintain your?
In my practice, it's after 1. You give them 1 injection. You have to make sure they come to you on Friday, because it's acid, really. Ascorbic acid is quite acidic, and they will have redness, they will have swelling, usually in your practice already. And then you send them home, like by Monday, they're completely fine. Sometimes next day, they're completely fine. It's not really something with a lot of downtime. It's really pain, but pain lasts like maybe under 1 minute. Like they have like tears, they're usually quite...
But how long would the benefits last?
Well, from 2 to 6 months. Usually as soon as they come back, they will come back to you.
Yeah, okay.
You have to really, because the most important thing is actually pain. Result is actually amazing. They love it, but it's so painful. Sometimes when some patients, I can see one of our doctors already cried, just hearing me. It's actually worthwhile if you're concerned about pain, like a classic technique to mix it with hyaluronic acid, like a skin booster. Non-cross-linked hyaluronic acid, because cross-linked hyaluronic acid on the eye will give you a lot of swelling and lumpiness later. Please don't do this. But if you mix it with hyaluronic acid, it's actually decreased pH, and they tend to tolerate it much better.
Have you tried to mix it with Botox? I like to add a bit of to do like a mesobotox in this area. It's in the same time works nicely on the crow's line.
Oh, that's a good idea. I like mesobotox, but I never even considered this. It's like in the same syringe?
In the same syringe. For example, insulin syringe, let's say 10 of vitamin C and 5 of Botox. So you over-dilute and you inject superficially. So you really work on these tiny, tiny lines.
Yeah.
It gives a bit of glow. It doesn't last long though.
How long?
Roughly 2-3 months as well.
Yeah, that's fair enough. That's long enough, really, for just 2 injections.
Wow. Yeah, you can combine with normal Botox, and let's say when I do a follow-up, I add vitamin C with Botox or hyaluronic acid as well. Also nice.
That sounds like a great idea, actually. When I was in Paris this year, mesobotox technique was really popular. There were a lot of data, and seems like it's very preferable because of the safety profile. You can just do intradermally pretty much everywhere, and they have quite good results.
I would say probably 30% of procedures now in my clinic is mesobotox. It's booming, especially neck area. Patients love it.
Do you mix it for neck with something?
Yeah, you can get, there's a brand called Mesotox, or you can just mix it yourself. And also depends on the patient, you can add different brands. For example, for firming in this area, I add meso cocktails with silica and vitamin C and Botox.
Yeah, silica is very good for neck, I found as well. That's a great idea, actually. Thanks for that. Yeah, interesting. But anyone else have some other tips and questions to discuss?
I used to use Brooks formula AHA peel for dark circles, and I would do it maybe every 2 weeks. By the time we'd done it about 6 times, it was usually pretty well fixed and stayed fixed for quite a while, 6 to 12 months. Then I got a carboxy machine, which I decommissioned after about a year because it doesn't work on cellulite, it doesn't work on dark circles. It's okay on scars, but not as good as subcision and needling. But I haven't used the vitamin C because I knew it would be really painful.
Mm. Have you tried lactic acid?
Yes, yeah. Subsequent to that, I've got a lot of peels that I use, and I had a 10% lactic, which is obviously not as strong as what they've used in this study here, but I don't know how they can use it weekly with the combination of lactic and TCA. The skin's going to be damaged when they're putting the second peel on, and they won't get optimal results. I need to wait a bit longer.
Because of the type of the skin, because in that region skin is thicker. So, because most of the patients I reckon from Egypt and Saudi Arabia, right, in the paper.
Oh, sure, and Mediterranean as well get this a lot. So you do need to look at the thickness of the skin for sure. So maybe they can use different products to what we could use. I would never use any of this on European product. Well, not that peel on European patients.
Mm. I'm curious to try lactic acid in this area, but I really don't know what to expect. Like,
It's pretty similar to glycolic. It's a bigger molecule, doesn't penetrate so deep, but the results are fairly similar. It's said to be a little safer. That's probably because it's bigger, so if you're not so good with your neutralizing, the patient doesn't suffer quite as much. If you don't neutralize glycolic acid really well, you can get in big trouble.
And it's quite aggressive, small molecule which goes quite deep inside.
It just goes and goes and goes and goes if you don't neutralize it.
Then badly, that's right. Especially in this area where it's so thin skin, I wouldn't be so afraid.
Oh, it would be terrible to get a scar there.
Yeah, patient would not say thank you.
Or even PAH. Imagine you treating the dark circles and giving even more pigmentation.
Yeah, you don't want to have hyper pigmentation in post-inflammatory and make it much worse.
Yeah.
Look, guys, Venus vitamin C, it actually works, but the pain is absolutely horrible. It's true, and it really have to be quite a good discussion with the patient what they want. One of my patients, she reported me quite interesting case of herself experimenting. She bought online the one of the derma roller, you know, like for home use. You know, she's very brave girl, and she decided to derma roller, and then straight away just a fresh lemon.
Oh.
Well, it actually works apparently.
I've had patients who have treated their freckles with lemon juice. I even had one who treated them with Ajax. It did work, but she needed a lot of steroid to calm it down afterwards. You just want to burn it. You can use any acid or alkali.
Kitty, I think you can actually tell a couple of interesting stories with your experience.
People, the things I've heard. I had someone who bought Aquamid off the internet and put it under her eyes. I still haven't got it all out. We've been going for years trying to get it out. So
I had similar, but she decided to put the glabella.
Oh.
Because her logic was that doctors are being greedy, and that's why they use temporary fillers. So, but she's very smart. She put permanent, and she just like bluntly, it's a hole. Let's inject in a hole. I don't know how she was so lucky. But the most interesting that it's all ended up here. just in her malar area. I don't know how, and it was quite badly infected. And as you can imagine, no plastic surgeons in Melbourne wanted to touch her. Like, nobody wanted to do anything. And she had to fly all the way to Istanbul because she found plastic surgeons who consented to take her. My God.
Wow. It may not have been Aquamid, it may have been Amazing Gel, because Aquamid doesn't have much of a history of migration, but there's copycats, and the big one is Amazing Gel from China, but they package it so it looks exactly like Aquamid. So there's quite a lot of reports of the polyacrylamides traveling, and they can go a very long way, but I think that's the cheaper knockoffs. But it's done a lot of damage to Aquamid, so yeah, it's not used too much now.
I think there are a lot of counterfeit products online. I think.
Why would you buy online?
Oh, she's smart. She knows. She watched the video.
Yeah. Some of them do know. Or think they do.
Yeah, definitely.
Actually, can I just jump in quickly? Just speaking of filler under the eyes, I once saw a talk at IMCAS, people talking about, because in a lot of Middle Eastern people, they have this the muscle that shows up, it's actually the muscle. So they have very thin skin. So what this doctor did was she used hyper-diluted radius and injected with a cannula superficially.
Wow.
I haven't been game to try that because we've always been taught to inject filler deep in that area. But that's because if we use HA filler and if we inject superficially, obviously you're going to cause a Tyndall effect, you're going to cause swelling. But what this doctor did was she used hyperdiluted radius to cover the redness of the muscle that was showing through the thin skin in Middle Eastern people, and then seemed to have worked really, really. The result was very amazing, actually. Might be able to still find that lecture on the IMCAS Academy. But I'm just wondering whether anyone has tried that here in Australia.
I have.
Who?
I've been I have been doing that. Yes, I hyperdilute radius and inject it like a wash in that area with a cannula.
Interesting. Yeah. How much you dilute it with? Like what do you dilute it with? And how much?
Look, you can do it 1 to 4. You can do it 1 to 6. I mean, apparently, higher than a 1 to 4, you're not going to get much of collagen neogenesis as you want. But this area, depending on the skin, how thin it is, I do it 1 to 4 and inject very little with a cannula, 25 gauge, just very, very, small threads like that in that area.
So if you dilute it with saline or lidocaine?
Well, part and part. I mean, we have the Radius Plus, which has a lidocaine in it. So you can use just the saline with it. I mix, actually. I use half the amount lidocaine and half the amount of saline. And obviously it's without adrenaline, if you're going to use lidocaine to dilute with. But mix it very well, with, and then just inject a small amount. It doesn't really take much of radius in that area,
So if you have 1 ml of radius, you use 4 mils you add 4 mils of saline to it.
Exactly. And I would do, not just under the eyes here. I could do also the neck, part of the neck, or the back of the hands.
Wow. Okay.
Yeah.
Cool. Yeah.
Radius meso is very nice, actually.
Yeah, it's very nice as a skin, strengthening material. It's beautiful. And apparently under the eye, it has this effect of lightening the color as well.
How long do you find radius lasts for that purpose?
Look, I haven't been doing that long enough to say it lasts for a year or a couple of years under the eye, but I've been using radius for many years in the other, classical protocols. and you know, it lasts a year the normal way. But for under the eye, you know, you're always under treating, so you're not going to promise, you know, it's an addition to what you're doing with Radiesse to the patient.
And you haven't had any complication with like nodules or anything, formation?
No, I haven't.
That's great.
I do remember seeing a patient many years ago who had Radiesse put in his tear troughs. It probably wasn't diluted or very much, and he was left with these white sort of xanthelasmas of Radiesse.
That's right.
Visible underneath
but that's not what we do, because we're not using it as a filler. It's not as a filler in that area. It's just as a skin strengthening, you know, therapy. That's all.
Yeah. You use it almost like a skin booster. Just
Yeah, I actually used Vital, and Vital caused lumps. You know, Radiesse, diluted Radiesse doesn't.
Yes, because Vital is still partially cross-linked.
Yeah, no, yeah, that's right. But you know, they promoted it as a skin booster, and I found it not as good. Yeah.
See, when I was in INCAS in Paris a couple of years ago, they were in Europe. They used mostly, if they're using it superficially under the eyelids, under the eyes over the eyelids, they use Vital Light.
Yeah, I know, but I actually stopped using Vital before Vital Light comes into the market. Yeah.
So how much of the Radiesse do you put in out of the 6 ml?
Probably, you know, probably 0.4 in each side, and that covering the whole, you know, like, you know, under the eye. You know, you come even to the mid cheek sometimes. Yeah.
So same as they do the PDO powder, right? The Koreans use a lot of PDO powder there. Similar thing.
I don't
just
use
Radiesse.
Yeah.
Well, no, because it's not TGA approved. So.
No, I don't. I never done PDO in any part of the face anyway, so I can't comment on that.
Yeah. Interesting. Have you used Sculptra that way?
I never use Sculptra because, you know, with you know, like the news or rumors about nodules, I haven't really, I have not used Sculptra at all.
It does make
no, they use it in China. They use it in China and in Taiwan. Yeah, for 18 ml dilution.
Yeah.
But
I used to use Sculpture in sort of the tear trough, and it did work well. I never had nodules, and I did get good results with it actually. I haven't for many years.
Yeah, they told us to use it for tear troughs probably, I don't know, 2002 or something like that, and they rescinded all the instructions and then now say it's not indicated. Admittedly, I didn't get nodules under the eyes, only top lip, nasolabial fold, marionettes.
Necks. I do a lot of necks with Sculptra already.
Yeah, it's great for necks.
I haven't seen anyone with any glasses of wine yet.
Unlike board meetings, we don't have our partners available to keep topping up the wine glasses. What's wrong?
I have mine here.
Sorry. You missed my glass of wine at the beginning,
Wrong had one.
I think that's why alcohol consumption's gone 70% up. It's all the webinars.
Enough for others not to be jealous. Run out of wine right now.
Oh, that's bad.
That is bad. It is bad.
Good.
You get to go to a lot more bottle shops now, because if you want more than one bottle, you've got to go to the bottle shop.
Don't tempt me. I've got liquor land downstairs. Okay.
So
I'm winding up. I've got to go. So thank you. It's been very pleasant.
Thank you.
Thanks, Ron.
Cheers, Ron.
Thank you
Have a
very
lovely
much.
night, everybody. All the best. Take care.
Thanks,
Yes.
love.
Good night.
Thanks for organising, Larissa.
Thanks. Bye.
Rachel, what are the polar lights at the back?
Didn't you know Rachel is in Norway?
I'm in Norway. They're yeah, it's my virtual background. Now I don't know how to get rid of it. I like it.
I guess everyone was watching.
The time.
Good night, everybody. It's been
Bye.
terrific.
Bye.
Thank you very much.
Thanks for coming.
Yeah, thanks very much.
And thanks, Larissa.
Good night.
Thanks, Larissa, for that.
Marisa, so good.
Thanks, Larissa.
Awesome.
Bye.
Thanks, Gordon.